Graston Technique, manipulation or electrotherapy sham for thoracic spine pain. Given the widespread use of adjunctive approaches for spine and extremity disorders, one might assume that there is a strong base of literature evidence to support the use of various taping and soft tissue myofascial approaches, in particular instrument-assisted soft tissue mobilization. Unfortunately, this is not the case. Complicating the interpretation of the existing literature evidence is that there are now a number of IASTM approaches patterned after the original approach, Graston Technique. One might also assume that there are a number of strong studies for the management of thoracic spine pain with manipulative therapy. Again, not true. Many are case reports or without comparison to other treatments. This is why the study we will now discuss is unique in that it attempts to determine the effectiveness of Graston Technique used in the management of thoracic spine pain compared to either spinal manipulative therapy or placebo. Before we review the study, let's discuss more broadly the prevalence of thoracic spine pain and presentation to chiropractic offices. Thoracic spine pain has a one-year prevalence of around 30%. The 2015 NBC Practice Analysis of Chiropractic indicates that thoracic pain patients represent approximately 11.5% of all presentations seen in practice. Surprisingly, there are only 2 published RCTs that focus on the effectiveness of SMT for thoracic spinal pain. In one by Schiller, the SMT group reported lower pain intensity and greater lateral flexion range of motion compared to a sham group immediately following the 2 to 3 week treatment period. However, there were no differences after 1 month. In another by Lathola et al., thoracic spinal manipulation, needle acupuncture, or placebo electrotherapy were all similar in reducing pain in female patients with recent onset mechanical thoracic spinal pain. The study results showed small differences in pain reduction favoring manipulation 1 week post-intervention. However, these differences were not clinically important. Given the current study specifically uses Graston Technique, let's discuss its general approach and purpose. Through the application of metal tools to the skin of patients, the clinician purportedly is able to isolate soft tissue adhesions and restrictions and treat them precisely. It's not a novel approach. It originated from a traditional Chinese medical treatment called gua sha, which used bone or jade tools or later metal coins. What is or was unique about Graston was the design of the tools and the protocols developed specific to specific structures, and the tools had unique beveled edges. Practitioners believe that these stainless steel tools magnify the perception of myofascial adhesions. There are, with the current study, about 22 studies at the time of this presentation. Many are case reports and are part of multimodal care without comparison to other treatment approaches. 4 case reports are by one author in 1 year, published in the Journal of the Canadian Chiropractic Association. Case reports include trigger finger, de Quervain's, plantar fasciitis, Achilles and patellar tendonitis, ankle sprains, and low back compartment syndrome, among others. Although limited, there are 2 preliminary studies that show an increased blood flow with the use of the Graston tools and improvements in shoulder ranges of motion among baseball players. Like all therapies, there are some risks and common reactions. These include petechiae or redness during the treatment and some soreness the day after treatment. In rare cases, skin reactions occur which may last for 24 to 48 hours, including extreme black, blue, or purple bruising. Now to the current study entitled Spinal Manipulative Therapy, Graston Technique, and Placebo for Non-Specific Thoracic Spine Pain, a randomized controlled trial published in Chiropractic and Manual Therapies in 2016. The original inclusion criteria was pain less than 3 months duration. However, recruitment was slow, so that this was amended to include also participants with any duration of pain. There were 3 treatment groups: In the spinal manipulative therapy group, high-velocity, low-amplitude adjusting maneuvers were delivered by either student interns or supervising DCs at Murdoch University in Perth, Australia. And in the placebo group, detuned ultrasound also was delivered by either student interns or supervising DCs. For the Graston group, student interns certified in the first level of Graston administered treatment. There are a number of questions unanswered by the description of this group in the study. We don't know which of the many Graston tools were used. For example, in the images, you can see that their design and size are different, and they're numbered. They also are nicknamed differently, for example, the handlebar, eraser, or scanner, etc. Secondly, we don't know where or how these were applied. Outcome measures included a VAS and Oswestry disability score. Although the visual analog scale is a 100-point scale, pain scores appeared to be converted to a 10-point scale. It's important to note that baseline pain scores were around 5 out of 10, and the Oswestry disability scores were around 28, both moderate. These were taken at baseline, 1 week after treatment, upon completion of the 4-week intervention, and at 3, 6, and 12 months. So let's look at how the pain scores changed after treatment. At 1 week, the Graston group was 4.7, SMT 5.1, and placebo group 4.7. At 1 month, there were distinct differences, with the Graston group decreasing to 3.4, the SMT group to 4.3, and the placebo group to 4.2. But again, the question is whether these are clinically significant changes. In other words, could all patients agree or perceive a reduction of moderate pain from a 5 to a 3.4, for example? At 1 year, there were no real differences among groups. There was a concern about dropout rates, but at 1 year. At 12 months, the numbers lost to follow-up was for the SMT group 28%, for the Graston group 45%, and for the placebo group 41%. There are a number of limitations to this study. Much of the therapy was provided by student interns. We don't know which tools were utilized and whether there were any standardizations to the treatment using the Graston tools. There was a large dropout rate, at least at 1 year. Baseline pain was on average a 5 out of 10. Is the small decrease in pain clinically significant in any of these groups? Also, given the moderate baseline pain of all groups, would patients with higher pain levels have responded more? A more recent study was just published for low back pain entitled The Effect of Graston Technique on Pain and Range of Motion in Patients with Chronic Low Back Pain, published in Physical Therapy Science. We won't go into depth with this study because it was a very small study with only 30 participants, 15 per treatment group, comparing Graston to exercise. Although the results indicated better outcomes with Graston, there are statistical concerns given the small number of participants. Yet this hopefully indicates that Graston and other IASTM approaches will be continued to be studied. So as usual, where does this leave the practitioner who uses this approach and feels it to be successful regardless of the results of the study we reviewed? In the interim, be your own scientist until more evidence surfaces. Keep track of results and approaches used on your group of patients. Identify them by diagnostic group, baseline outcome measures for pain and function, and types of tools and techniques used. Even better, publish these as case reports or case series.